Good morning, everyone. My topic is retro mode. Does it provide newer insight into dry AMD? AMD, as we know, it is the third leading cause of irreversible blindness among population 50 years or more in India after diabetes and glaucoma. Incidence of dry AMD is 85 to 90%. Rest of is contributed by the wet AMD. Number of people affected is 196 million in 2020, which is likely to be doubled in 2040. Main site of pathogenesis is Bruch's membrane, RBE, and the choroidal structure. As we know, drusen's are the extracellular material deposited between RBE and the Bruch's membrane. Why do we need these modalities? Drusen's less than 25 microns can't be detected clinically. So various modalities like OCT, OCTA, FAF, and retro mode were explored. Retro mode is specifically designed for the RBE status. It incorporates the infrared lasers with the property of deeper penetration. It has right deviated and the left deviated aperture. Advantages: it is a sensitive modality for detecting drusen and the smaller drusens which are easily detected compared to the color fundus photo. It gives directional information and the subtle features of the low-lying drusen. It gives accurate characterization of the retinochoroidal deposits and can detect the smallest alteration. Aim of our study was to study the role of retro mode in the early detection and to compare it with other pre-existing available modalities on the multimodal imaging system in dry AMD. It was a prospective, observational, and the cross-sectional study done on 409 eyes of the 207 patients. For the study purpose, 3 groups were made according to the size and the number of drusen. Group 1, no AMD, Group 2, early AMD, and Group 3, intermediate AMD, which were further classified into 2 subgroups. Subgroup A, eyes with drusen size 63 to 125 microns, and subgroup B with drusen size 125 to 250 microns. Mentioned below are the exclusion criteria. Drusen size less than 63 microns were giving the number more false count rate, so that were not included in our study. This is the color fundus photo, FF, OCT, and retro mode picture of no AMD, early AMD, and the intermediate AMD. Apart from this, subfoveal choroidal thickness was also measured using the EDI OCT and also vessel density on the OCTA using these 9 quadrants of ETDRS. This is how we measure the number of drusens using the software dot counter, and area was marked manually and counted using the software image J. Results. This is a demographic profile of the patient. This is the comparison of the number of drusen detected by the color fundus photo, FF, and retro mode in various stages of AMD, which shows the significant difference. Apart from, we also compared color fundus photo with retro mode, with FAF and FF and the retro mode. And also the extent of disease. We can see here the area of extent was more calculated by the retro mode. And as the disease advances, the thickness of the choroid and the choriocapillaries decreased. This is the pattern trend. And we compare the vessel density on the OCTA with the color fundus photo, FAF, and retro mode. As we can see, as the disease advances from no AMD to early to intermediate AMD, the vessel density decreases in each quadrant of the 9 quadrant of ETDRS. So, lesser the severity of disease and the smaller the size of drusen, more chances of false positive counts. FF shows more number of drusen compared to the color fundus photo and retro mode in smaller size drusen in early detection of the disease. As the deposition becomes more defined, that is in the intermediate stage, pickup is more on the retro mode. So to conclude, retro mode is found to be better diagnostic modality than the color fundus photo in detecting more number of drusen and also in the area of involvement. Retro mode findings were co-relatable with the OCTA in the various stages of the disease. Though superior, as found in our study, this mode can't replace other modalities at present. It can act as a complementary investigation in early detection of this disease. Limitation: this was a cross-sectional one-time study. Further longitudinal studies are needed to prove superiority of the modalities over present modalities. Artifacts and therefore false positive counts can't be eliminated. Thank you.
So from the technological point of view, what is the difference between retro mode and near infrared imaging?
Retro mode has a two aperture, right deviated and the left deviated. So by blocking the one side of the lesion, we can highlight the lesion from the other side, which can pick up the subtle features.
So is it the same as near infrared but in stereo?
Retro mode is more superior than the infrared because it can detect the lesion from the one side by blocking the other scattering lights.
Okay, and there's a difference in terms of the progression of AMD in patients between those who have soft drusen and those who have hard drusen. So does your study reveal any information about that?
We noticed the progression was more in the soft drusens compared to the hard drusens into the neovascular component.
Did you mention any of that in the presentation?
No, it was only dry AMD component was included in this. That's why.
What is the role of OCTA in early AMD? You told
Sorry?
OCTA, you compared OCTA with in early AMD. So
As the disease advances, the thickness of the choroid and the choriocapillaries decreases.
does retro mode helps in differentiating early AMD like that?
We correlated the site of the drusen and the thickness at that location, and the site where the drusen was present, the thickness was comparatively less.
You measured the thickness of the choroid or the vessels in that area?
Choroid and the choriocapillaries. We excluded the less than 63 micron size because it was giving more artifacts. But as the disease advances, just like in the intermediate stages, the size of the micron of more than 125. As the disease becomes more defined, retro mode picked up the more number of drusens. Fluorescent angiography is an invasive mode of, that's why retro mode is better.
Okay, thank you.
Thank you.